Hello, everyone. Good afternoon. Welcome to the PrepMD Regional Device Clinic Seminar. My name is Aileen Ferrick. I'm a nurse practitioner. I've worked with cardiac EP for over 40 years, and I was privileged to be one of the co-authors of the HRS Remote Monitoring document that I hope most of you are familiar with. I'm also a PrepMD consultant now, and really looking forward to today's discussion. So our topic is how to build infrastructure into your cardiac device clinic to make it run as efficiently and stable, to have it a stable clinic within its life cycle. And we are very fortunate today to have Kent Seckinger, who is director of the consulting services for PrepMD. He has worked as a technician in several device clinics, most recently at Emory, but I'll allow him to, talk about his experience himself. I do want to do just a few little announcements. One is we have prepared some questions for discussion, but we'd like this to be a very interactive program. So I'm going to invite all participants to ask questions, to make comments. I'll sort of prompt you when we're ready for you to do that. And throughout the entire session, the chat algorithm there is available for you to write in some questions. And if you want to have an interactive discussion, then you can raise your hand and we'll invite you to unmute yourself. And then if you don't want to be seen, we will tell you to, don't open the video option. And then you can ask your comment, make your comment, ask your question. I do want to remind everybody that the meeting is being recorded. And then after we finish with our discussion today, we have a lot to talk about in a short period of time. If you have any further issues or questions that you want to address, we do have a way for you to be in touch with us. It's hello@prepmd.com. Okay, so with that said, I'm going to start by sharing my screen because what we are going to sort of start to talk about a little bit is what the life cycle of a device clinic is and what some of the components are. So I'm going to turn it over to Kent. Kent, if you want to tell people a little bit about yourself, go for it. And then talk a little bit about the components that are related to this loop of possible inefficiency in our structure of our device clinic life cycle.
Yeah, sounds great. Thanks, Aileen, and I appreciate the opportunity to be able to have this discussion. It's one I'm super passionate about, and it's an important topic. But just a little bit about myself. I've been in this space, the device space, for 20 plus years, with about half of it on the industry side, and then the other half, I would say, within the healthcare systems as well. So during about the past 8 years, I've been here with PrepMD, and I've had, the privilege of being able to work with clinics of all sizes and structures all across the country. And it's kind of interesting. It leads to this cycle that we're talking about here, and that's a pattern that we've kind of seen as we've talked to various different people with various different sized clinics, institutions, private practices. Everybody seems to pretty much have this common cycle that happens. Where they may land in it or how they may handle it is, of course, going to differ and be unique to each institution. But basically, what we're looking at here when we talk about the cardiac device clinic life cycle is, I think many people will be kind of familiar with how this works. It's really more of a structure that kind of centers around maintaining staff and losing staff, and when you do, the domino effect that happens after that. So it generally starts with staff turnover, as everybody has probably had some of their own experiences with that. Once staff turns over, it then moves into the clinic has to start to identify somebody else. It's very difficult to find somebody experienced. So we've talked to clinics that could take 1, 2, 3 years to even identify somebody if they do, especially having anybody with experience. So that generally then leads to folks that they will hire and then have to put through some pretty extensive training because they may not have device-specific training. And during that time, of course, since the advent of remote monitoring, that just creates a continuous volume increase in backlog, which can then create further overload on the clinics, especially for the experienced folks, tenured folks who have been there, having to manage that. In addition, once they do find somebody, having to proctor them, train them, which leads to more burnout, which can repeat the cycle. So, and then again, you'll have some inefficient workflows that might fall into those places too. So these are kind of the four pillars that we talk about. And again, I think what we've kind of identified when we talk to folks and heard from other people is, I think is interesting. This kind of comes about from the capacity structure of the way that clinics operated on more of like a calendar-based system before remote monitoring really became a standard of care, and particularly as remote monitoring became more RF automatic. So trying to actually look at this life cycle here is really looking at the clinic structure and the way that it's been and how it's adapted or not adapted to the changing technology that's needed.
Okay, great. So that sort of gives us, something to refer to as we're having our discussion today. I am going to stop sharing just so we can look in the chat room and be able to have an interactive discussion. But I guess one of the first things I'm going to ask Kent is, so how do you feel clinics, operate with their workflows and dealing with problems that are on this life cycle? Is it more reactionary or proactive in how, we sort of work our clinics?
Yeah, no, it's a great question. And I think most clinics do the best they can with the structure that they're in right now. The challenge has really kind of been that clinics, they're operating from a dramatically different, standpoint versus the past decade. So, especially with the growth of remote monitoring. So, I think that the way most clinics are staffed and trained and the way they support operations, that's kind of evolved over the years since remote monitoring came into play. And so it's a matter of them having to deal with what they've really had to deal with. We've talked to several clinics, and one of the first things that many people will say, because things really do center around staffing, is, they feel like they're doing everything that they can to keep up with what they have. But I think they are doing the best that they can with what they have. So the proactive part of it is kind of what this discussion is really all about. How do we shift this structure so that the infrastructure of the clinic itself is parsed out into sections where people have their certain responsibilities for their areas of certification expertise, whether it's admin, technician, whether it's therapeutic device reprogramming or diagnostic, ILR type assessments.
Okay, so I think we're going to try to go through each of the pillars of, the components of the life cycle, so we can sort of just raise some questions of problems that each of your clinics out there address. So I'm going to throw it out to the audience. Again, I invite you to either raise your hand or put a question or a comment in the chat box. So talking about the first pillar being staffing, I'm going to ask how do people calculate their clinic staffing needs? Part of the document that we did publish in 2023 put a recommendation of 3 full-time equivalents to 1,000 patients in the device clinic, including for remote monitoring. I guess I wondered if people are actually utilizing that calculator. We also had a little tool that you could plug in the types of devices that your clinic follows and information about your staffing and time off so that you could sort of customize it to your individual needs. So I'm going to throw that out there to you guys that are participating in the seminar today. How do you calculate your clinic staffing needs? And maybe we can even go a step further and say, once you do calculate those needs, how do you recruit somebody? Where do you find the people that you are now going to include in your device clinic? How do you find people that have any experience? Where do you look? And how does that work for you? And then how do you maintain those numbers? So if you have staff that, or I was just before we started the seminar talking about one of my colleagues who is dealing with two people are going out on maternity leave, and she now has to deal with that in her clinic. And then people obviously have to take vacation, time off, sick time. Like, how do clinics, if people want to share, how do you accommodate for your staffing needs when things change? Anybody want to?
Looks like we have a question already here, by Aileen from Mary Johnson.
Okay.
Yeah. Says it seems to me that there needs to be, hold on, let me do this real quick.
Okay.
It seems to me that there needs to be a major change in terms of CIED clinician education. We have largely lost industry as the major source of training. Absolutely. EP attendings are also less often in the office and more in the lab with the advanced procedures and implant techniques that have come to be. Now, I think that's a great question. The education is key. It's key for a couple of reasons, especially to be able to have folks that are coming in to get educated. Again, like we talked about often when staff turns over, it's very difficult to find somebody who is experienced, so you don't have to train right off the bat. That's pretty much hands down. You're going to have to invest in some type of training. What I do think is kind of important for to discuss and just for for clinics to look at is what is the result of that training that you need to have, because it's going to be very different, I think, for how you parse out your clinic. If you're taking individuals that are coming in that are new that do not have any kind of education, then they may start with remotes, so more on the diagnostic side. So what does that look like? Do you provide a lot of OJT? I know that is a big thing that many clinics have to do across the country. As soon as they hire somebody, they're going right into a production environment, and it's kind of like thrown into the fire. Do the best they can, be able to have somebody to help them out, oversee some things, and then start doing some training. But they're generally doing it in the production environment. And then people can move forward into expanding that training into the therapeutic devices programming, things along those lines. So I think one of the things in training that's always been on the healthcare side that's a great thing for many institutions to look at is how does training look for you in your clinic to actually create a real pipeline of end to end for the folks that you might be hiring, especially if you're hiring somebody brand new with no training whatsoever. How do you start them? Do you want to start them on remotes, then have them trained on that? Do you want to look at training to be able to utilize platforms or other things so that you can help augment OJT remotely? The nice thing about being able to do things remotely is there's resources that you can lean on for doing that kind of training remotely as you take them through, and then going more into didactic and extensive training through programs that can take you through timing cycles, programming devices, advanced programming, those kinds of things. So I think a big lack that hasn't been out there is a complete end-to-end training that takes into consideration what it looks like for device clinics.
Yeah, so that's the third pillar of our life cycle discussion, but that's
They,
fine.
yeah,
Yeah,
they start. It all starts with staffing. So
yeah,
yeah,
yeah.
yeah.
And
I think with the pillars that you'll look at, there's the loop that goes back. Even
yeah,
if you lose the staffing, there are everybody's going to have their different ways in which they find staff. But it's going to come back to training, what you're going to have to do with that staff, and so on. Yeah.
right. And I guess one of the things that I also want to ask about staffing, and another thing that was in the the document, the recommendations is and people chime in and let me know how you operate. Some clinics just use clinicians, whether it's device techs, nurses, and then they're overseen maybe by advanced practice providers where, the initial read is done by a technician and then it's overread by the advanced practice provider who may then have to make a clinical assessment and an action, for that patient. But there are so many other components to running an efficient clinic that you don't always need to utilize your clinicians. I've wondered how many clinics out there use their administrative staff to do things like assure that the patient is connected, because I mean that's key to doing remote monitoring is your connectivity. Um, as far as scheduling, especially patients that still have inductive or manual transmissions. And now with some of the newer technologies, such as the leadless devices, as well as the subcutaneous devices, they have to make manual recordings. So all that has to be scheduled. People that are like lost to follow up, like, do you guys out there utilize non-clinical personnel in your in your clinic? And is that included in your sort of calculation of your staffing needs? I'm,
We had another question pop up here,
okay.
and it kind of leads to I think what you're alluding to with all of these different positions and being able to put people where they need to be for what their expertise is, which can lead to burnout and things along those lines. And I think this is a great question that speaks to what you were just asking. Um, One is we have utilized that tool to a point, but it
Okay.
is not fully supported by leadership. Every time we have someone on leave, we have to scramble, and this has burned some nurses out. I think ongoing training is missing. We do a good job getting people onboarded, but then there is little support funding for conferences after that. So I think we're still kind of back on this training portion part here, though,
Okay.
and the support for it.
Which
Um,
is great. I guess what I'm going to ask, in your training portion, so what sort of resources do you utilize? So I know that a lot of people use the industry websites, right? There's Medtronic Academy and Educare from Boston Science, and I forget what Abbott's is called. And I'm not sure if Biotronic has a program, but there are a lot of institutions that utilize those programs for training. There's also the whole EBRI exam preparation, like utilizing those sort of resources, for patients, I'm sorry, for clinicians that are learning how to take care of patients with devices. So, does anybody want to share what they use? And I think my next question would be, and do you have a protocol, like a timeline? So if that's how somebody starts, then how do you get them into the clinical environment? And then how do you train them in the clinical environment? Like who do you use to train them? And then the next question would be, would be what I think that question on chat was alluding to, is how do you keep people updated on things like the leadless pacemakers and new devices on an ongoing basis?
yeah,
Um,
we're getting some chats. We're getting some
okay.
questions coming here.
Unfortunately, I'm not able to see the
Are
chats.
you able to see the Q&A little icon down there,
Okay,
Aileen?
got it. Yep.
Yeah. If
Okay,
you
got it
and then
now.
there's also some in the webinar chat. But
Yes, I see that. Yep.
um, so I want to just touch real quickly on the last question that we were talking about, where Aileen was talking about the different tools for training. From this one, where the individual had said, "What we have utilized that tool to a point." I suppose, are you referring to like PrepMD's accelerator training tool that we provide? I just want to ask that question real quick to clarify. I'm assuming that's what you were talking about, because it's not support. If you're saying it's not supported by leadership, and then you have to scramble and get people burned out. So the ongoing training is missing. I would agree with you, and it can be hard sometimes, I think, for leadership to understand the benefits of a training program, especially when there are these vendor supported training programs out there, but those are very it's kind of like go do it on your own type of training program. Whereas what I've seen and what we've seen talking to various clinics across the country, when you do have this turnover and you have to train people, there needs to be some kind of structured vendor agnostic training program that's going to take people through the various stages of what their duties might be, their workflow might be in a clinic. So I think that would be a great conversation to have, to be able to get leadership behind some of the support. And that is really when we go back to talking about the device clinic lifecycle. That's really the point to show leadership. And this could be a further discussion later on. But what it's pointing out and shining a light on is that clinics are having to deal with still an old way of workflow without the infrastructure and the change that they need moving forward. So that's a great question.
I think that's something, because I see now I can see the questions here that Amanda had said that she had a hard time, always getting her healthcare system to allow them to have additional FTEs. I guess what I'm going to say is, how do you present it to your administrators? And I have had the experience, I've said this a number of times. I am a nurse practitioner. I'm not a business-minded person. But I knew when remote monitoring first came out and the ILRs came to play that we did not have enough staff to be able to manage all of the data volume that was coming in. And so I did try to put together a business plan, basically saying that if we had help, additional people, and really had patients on schedule, that we were then able to bill and generate revenue. It's not all about revenue, obviously, from our perspective, it's about taking care of patients. But I think in administrators' minds, you always have to give them the business end of it. Maybe, Kent, you could talk a little bit about what you have that data on how much it costs, turnover costs,
Yeah.
and do administrators really realize that how much it costs to hire somebody, train somebody, and retain somebody? Maybe you can talk a little bit about that.
Yeah, no, that's a great question. And there's Andrea kind of is alluding to that as well, talking about the funds to do training for a specific training program can be costly, and leadership doesn't usually want to pay. And that makes sense. It completely makes sense. And I think where it needs to resonate with leadership is what the actual cost of not having folks that are trained come down to. When you go back to the initial part of losing staff, again, training really comes into play because you're having new staff having to come in all the time that may not have the experience that they need, especially off the bat. There's always going to be long-term training, but what we're talking about here is in this cycle, in this constant turnover, once somebody else new comes in, there's a big lag during that during that process. Not only the time to find somebody, but then the time to train that person. And during that time, remotes continue to come in. There's backlog that continues to pile up. That backlog is loss of revenue. If we're talking about leadership and speaking to folks who are paying attention to that, it's also increasing liability because it strains the people who are still there, their ability to keep up with everything coming in. And it's no fault of theirs. It's just a product of the structure that it's in right now. That's also something I think leadership may have not seen in the past before, because we've taken a system that was more calendar based still, and now it's still being utilized to without structural change to be able to try to handle this volume. And it's not possible. So when you look at the loss of revenue from a leadership standpoint, they may not realize how much regular billables go by the wayside because their existing staff that are already extremely spread thin are just trying to keep up with taking care of patients and making sure they're not missing anything clinically actionable. And at the end of the day, I've been in this position. I know many of you have been in this position. That's what it's all about. And if we're very spread thin, whether it's having to proctor somebody else while we're staying on top of, keeping up with seeing patients in clinic, also, doing a remote triage if we're combined in that way. And again, back to trying to train somebody else, that creates more stress, more burden, which leads to further burnout, which leads to further turnover. And that's a tremendous cost to an institution, to leadership. And that's something that I think, is we would like to help out in, continuing this conversation and providing, clinic managers and folks that are in the clinic having to deal with this resources so that they can go to their leadership and make this kind of case. But I'm sure if that makes sense, people who are on the ground, there's a lot of revenue that's lost that if leadership sees this structured training program on a consistent basis, they can save a lot of leakage from revenue.
I think one of the other things, in dealing with administrators is having things documented. And that was one of the things we also included in the document is, to really figure out what your staffing needs are, the roles and responsibilities of your individual staff members, whether it's clinical or non-clinical, should really be written down in a standard operating procedure manual. Um, uh, and then, what the clinicians are responsible for as well. And I think, and your training protocol. So, what you do for didactic training, what you need to utilize for clinical hands-on training, how you have to, take your experienced clinicians and utilize them to train so that now they're not able to see and do as much as they would normally do when they were not training somebody. All that has to be clearly defined because then you can refer to that when you're appealing to your administrative people, your supervisor people about getting the support that you need, whether it's from an outsourcing situation or whether it's just getting more, staff for yourself. Anybody, I'm just looking to see anybody want to comment on your training protocol? Do you have a written protocol? I've seen a lot of clinics now having a lot of concerns about their administrative staff pushing them to have uh, clinicians be ready to be independently caring for patients at 3 months, 6 months, a year. I guess I would love to have a little bit of a discussion about how you all deal with that and what your sort of estimate of how long it takes for you to feel that one of your clinicians could independently follow patients without your overseeing and guidance. Does anybody want to raise their hand and talk about it, or
We've got some,
more questions?
there we go. Um, we're getting some questions coming in. Can you see them, Aileen?
Yeah, I see from zero to hero takes about 9 months for my comfort, says
Yeah,
one person, Jay.
yeah.
Okay. But
I do see one here that I think is very telling when folks are talking about there's one, bio, as you mentioned, bio basics and beyond, Mastery, Medtronic Academy, all of the vendors do have training programs, and they always have. I think one of the important things is that's with the way there's having a structured training program, and I think there's a couple of folks that have mentioned in here, like having a more formalized, structured training program. Even many folks who go through the academies that industry provides, which is great. I know it's probably still the situation where many people who are still in the clinic during that short period of time that are experienced and they're onboarding somebody new. There's a lot of proctoring. There's a lot of, OJT that goes on, which does, reduce productivity on both the experienced person and the person getting trained at the time. So I think that's where somebody was mentioning having a structured training program that meets your clinic's needs and is also supported internally in the operational environment on a day-to-day basis. Whereas the industry supported like Medtronic Academy, that is great many times for after work as you're going on, as you're studying on your own to some degree. But when you're looking at a structured program, that's going to help you get people up to speed and onboarded quickly and even supported during your production environment. And I think there is the case to be made for leadership to look at bringing a program like that into play because it also directly affects and leads to retention. It's a benefit for people to want to go to places where they have these programs formally implemented in the practice itself, versus telling them to go home and at the end of the day and jump on and read Medtronic Academy.
Right. And I think that Jenna has a good point here. She says she uses ATI to onboard her last three nurses, but but you're absolutely right, Jenna. It's not just the clinic. You're being pulled to go to MRI or go over to do, an interrogation in the emergency room, or I see you say echo, surgery, turning devices off or reprogramming them. All that is additional training, and you're also pulling out of your clinic and meaning that you have less availability to do your regular, daily work. And then when we talk about the second pillar on the life cycle, which is the data volume, so this is activity volume that is contributing to the burden on the clinic, but also the daily volume from remote monitoring as far as the alerts are concerned. And how do you address that? How I would love to hear from clinics on do you have two separate staffing groups, one that does remote monitoring, one that does in office device checks? And if you do they rotate back and forth, or is that their permanent place? Because I've heard of a lot of different models. There are a lot of places where people do remote monitoring in the morning and then device clinic in the afternoon, or they just do remote monitoring, or they, do inpatient, and the inpatient EP, advanced practice provider, they may be the ones that are responsible for doing the MRI, echo, surgical stuff, and the outpatient advanced practice providers, or whoever the clinicians are that are doing that in your particular institution, are responsible for the outpatient. Anybody want to comment on that? I see here Jay says hybrid remotes from home, some days each week, and so some days do, I guess, right, remote, and some days do in clinic. So is that something that is like scheduled in advance, or is that something that's sort of on the fly? Uh, and hey, you're totally welcome to jump on. You can keep your video off if you don't want to be seen, but love to hear people's
Yeah, we're
comments
getting.
in person rather than
Yeah, I would love to hear
just
people just
reading
start
them.
speaking up. Yeah, it might be they're starting to come in. I do see others are saying they clinic staff only as needed, and then for remote coverage. So it seems like there is a good mix of separate, where separate teams for remotes versus in clinic. Um,
And it looks like it is planned in advance, at least
mhm.
in Jay's clinic. So then that brings me to then how do you deal with the alerts? So that if you're a remote monitoring person and somebody has an alert that you see the patient needs to be seen, perhaps needs to be reprogrammed if it's like a false positive thing. So how do you coordinate that within your clinic so that now your in-office person is getting additional uh, patients that they may need to see? Do you leave openings in your clinic schedule to accommodate that if you have, the remote clinicians sending patients into the office environment?
It's,
Anybody?
one quick comment on that. As we're talking about the, usually having teams split for remote versus teams for in clinic. I think one thing that's important, and this can kind of go back to the life cycle of getting leadership, buy-in for the importance of training is if you're having a split of in clinic checks for therapeutic devices for pacemakers, ICDs, and so forth, where there's advanced programming, that individual, those folks are or along their expertise, their period of time in CID management, which is quite different from somebody who's just coming in who might be able to start working on remote. So concentrating a training program that creates a pipeline of getting folks trained for what they need, particularly in the production environment. So as you're starting someone out in remotes, I've talked to some folks that seem like it'd be very beneficial, and this makes a lot of sense, especially when you're creating a pipeline of people coming in working on a remote, then going to more advanced when they're in clinic. So having that support and a training approach with people who are just getting started, maybe purely working on remotes, is going to be a little bit different as you move them on forward to maybe when they go into doing device checks. So again, this gets back to where, like, I think a lot of the training programs, ATI, even PrepMD ourselves, having a training background many, many years ago, that train before things changed with remote monitoring, that training was primarily concentrated on advanced, programming, maybe industry led. But what we did is started to shift entirely to start supporting the healthcare environment. And that is a different training approach. And that's where we want to look at providing a really comprehensive training program that can go from very basic, fundamental, starting in a production environment, knowing that these clinic all clinics have a difficult time. And like I said, many times people are thrown into the fire. And that creates that burnout from their folks that are already on the ground. So there's a support function missing that I think we're looking to address here as we shift these programs around to be able to support the healthcare side. And I was just curious as to, particularly on the remote side, how do people kind of parse out when they bring in somebody brand new? What do results look like for you when you think of a training program, when somebody's up to speed, depending on what function they're doing?
Oh, Mary
Yes, please.
raise her hand.
Hi, can you
It's
hear
easier
me?
than reading
Yes,
all
we
this.
can. Yes, thank you.
Oh, good, good. I'm glad. I would put my face on, but I'm not quite sure how to. So rather than waste time, I'll just talk.
Sure.
Um, so thank you for having this. You're both really excellent. I'm a retired nurse practitioner. I spent my last 10 years at the VA, in device clinic. I've been with devices for 25 years. I was a device rep for 9 years with Boston Scientific, and I worked with an EP, attending one-on-one for 5 years in clinic, and then eventually I became very independent and spent my last 10 years at the VA running a device clinic and doing everything you're talking about, remote, MRI, surgery, the whole bit. I have to keep going back, you guys, to this issue of training. I think everything else is a moot point until we have people who know what they're looking at, know how to defend their position with administration, know how to
Yep.
pull their EPs in when necessary. So I really think frankly, I think that's why we're struggling. I think you could never have enough people if these people don't know what they're looking at. You
Absolutely.
could never. So I'm working with the American College of Cardiology. I started a CIED section here in Connecticut. My dream is to have a didactic basic entry level program in person
Hmm.
with a real good review course and eventually a certification exam. And people say, well, what about HRS? Well, what about HRS? I love HRS, but HRS has had 45 years to get all of this right, and we're still struggling. So
Yep.
all of these professional organizations have their challenges. I think ACC, HRS, working with a group of EPs, working with academic, centers, working with, schools and colleges. I just think we all need to get our heads together. How does this is a mini profession within the profession of EP. It really
Yeah.
is.
Yeah. No, I
Now,
think
Mary,
that's,
I'm
go
sorry.
ahead.
I
No.
was going to say, Mary, I did send you an email. I don't
Yes,
know
you
if you got
did.
it. So HRS is now the Allied Professional Council is trying to put together, recognizing that this is a huge need,
Yeah.
at least starting a training pathway where they're going to start with looking at like for advanced practice providers,
Hmm.
those that have cardiology experience, what would be the pathway to quickly get, or as efficiently and as quickly as possible, get them to be capable of independent practicing in
Right.
the EP area. So that's something that as you know, I know you're frustrated with Heart Rhythm Society, but I think that's something that you would be so valuable to contribute to that movement that they're trying to start now. So
Yes.
we can talk offline, but
Yeah, I'm happy to
that
help.
is
I am.
something.
Yeah.
Yes,
Yeah.
yes, no, I think it's going to take everybody. I think it's going to take HRS, ACC, and healthcare institutions. One of Hartford Healthcare in Connecticut actually paid for 9 of their device clinicians to join ACC so that they can come to my programs at the reduced price. So if
Uh-huh.
healthcare systems start to buy into this thought that we have to have formal education for this staff, everybody needs to understand this is a bit of a crisis.
Yeah.
Right.
Yeah.
And I
And
think
that's,
the problem is as you see all these comments, that we're talking about today, is that
Hmm.
administration doesn't always get it. They don't.
They don't.
So how,
no.
if they don't even understand the volume of work, the need for staffing within the clinic, how are they ever going to even, how are we going to teach them that
Yeah.
they also need to understand that it costs to recruit, it costs to train, and it is cheaper to retain, right? So
Yes.
what
Right.
are some of the things that we can do to actually retain people? We talk about burnouts. There was a question, Amanda had a question, how do clinics deal with burnout. I mean, that's a real issue when, as I said, one of my colleagues who has two that are going out on maternity leave and other people that are taking vacation. So the remaining staff are now totally overburdened. And how do you accommodate them? Like, what do you do, after they've done their due diligence and helped you get through a crisis? Like, what do you offer them, to help them have a bit of a respite? Does anybody have any comments, or has anybody had any ways that they have helped reduce burnout within their clinics? Please, jump on, and we're happy to have you speak up.
Yeah, it would be great. No, Mary, I would just add, I think,
Mhm.
everything you're saying is absolutely right. And that's one of the points of being able to start this conversation and put this call on. When we go back and, the initial topic subject of this talk is about this life cycle that's going on. And I think for leadership, one of the important things, as you said, before you have trained people who know what they're doing, it's a moot point for anything else.
Yeah,
It's until we have leadership and administrators understand that the this cycle that we're stuck in, because we see this all over the country, it's the same thing.
yes,
And it's because we're using an older model that doesn't have the capacity to be
yes,
able to fulfill what we need. And so showing the cost of not having trained folks, back to what Aileen mentioned, we're working together on a white paper to actually bring this to the attention of administration.
good.
So I think so they can see this bigger picture, because it doesn't matter if you have great software, if you have, whatever you have, in the structure that it's in, workflow efficiency is not going to do anything until you have a pathway where there's people that are actually able to do those workflows, and
Correct.
you can reduce the turnover. So there's, as this space has changed, there's a lot of talk and a lot of movement forward on what needs to be done. I think that what we're really aiming to do is start to bring in administrators so that they can understand that this is, the capacity is too much. The turnover is too high, and it'll stay stuck in this system until we can bring to their attention that is a different structure now that requires a different approach, and training being absolutely one of those. And financial part of it is very important, and it needs to be addressed. And so that's been something that we really want to do, so that people can go to administrators so they can see the absolute importance of it. I think sometimes if we go too quickly directly into administration with a training program, or say we need this without showing, why. From a
Right.
financial standpoint, that's where we get into the problems of administrators saying, "Well, that's too expensive. We can't utilize this." So creating tools, and this is one thing that we're really working on, to be able to support clinics to show leadership that here's what it's costing, not only just in remote billables, but also in burnout, retention, turnover, and so on
Mhm.
and so forth. So I think that kind of initiative is going to be what's going to really help get the support that people need to build out some of these programs that we're talking about.
And I'll
I,
say just
I,
one last thing, so I won't hog up the rest of the time. But the one last thing I'll say is that when we had our two in-person conferences here in Connecticut, I invited administrators and I invited the clinician, the EP administrators.
Mhm.
And I think that's how Hartford Hospital came around to paying for their people to join ACC. So when they sit in a conference and they see the complexity, their heads are spinning and they're like, what? This is what these people need to know. So
yeah,
that
and
helped
that
too.
and I think that more and more the EP administrators are getting that message, because PrepMD, we had a regional meeting in person down in Manhattan, in New York City, and one of the EP administrators from NYU attended, and was talking more about how they are getting more involved in knowing what's going on in the clinic,
Yeah.
and then that supports them to their higher aboves to be able to get resources to staff and train and everything that we're talking about today. The other thing that I'm looking at, some of the questions that people are saying, like, how do you reach management? One of the key things that people have said is that you have to have a physician champion. If you have a physician partner that will support you and go with you or represent you, however the culture of your institution or your environment is. Sometimes they will, as sad as that is, listen to the physician above listening to the supervisor of the device clinic who probably knows better. But that if you can partner with your electrophysiologist and have a physician champion, that can be very helpful in reaching administration. Okay, I think one of the fourth pillar of our life cycle here that we talk about is the workflow, and one of the key ways to make your workflow efficient is through software, whatever you're utilizing in your clinic to manage your data. And I know a lot of people were in a panic after PaceArt, was taken over by Pacemate, and now people are looking for alternative software. Maybe we can turn a little bit to talking about that if anybody wants to volunteer to speak out about how maybe they most recently chose new software or are in the process or need help with that. Does anybody want to comment on that?
Yeah, and while we're waiting for questions, I would just like to add, I think since we're talking about pillars and how they all go together, particularly with training and stuff like that, software itself as data management is just one particular pillar within what, the things that a clinic needs. They need staff, they need trained staff, they need monitoring support at times. We're always going to have turnover, so having some kind of support in software should also help that training process as well through that production environment. So I think that sometimes as we expect that administrators should understand that they need support for training, I think we should start to expect software to go beyond just pure data management and actually support real world training environment in the production environment as well. So I'll throw that out there too, as people, I'd love to know what people's thoughts are on that. That would also be great.
Well, it's interesting because we have two comments. One from Melinda, who is currently using Pacemate and has for the past few years and loves it. And then Amanda is commenting that they're ready to implement PrepMD and utilization of Omni, which is great because I think, I will promote, we're having I don't know if anybody who's on the webinar here today has been part of the leadership summits that PrepMD also sponsors. Our next one is April 10th. And some of the things that we're talking about today are going to be covered in that summit. One being how to put together a proposal for your administration in order to sort of sell the needs, or to identify and appeal to them to support your needs in running your device clinic, is one. And the other is a little bit of a discussion about software and outsourcing. Like, how do you choose an outsourcing program? Or how do you even identify whether you need an outsourcing or would benefit from an outsourcing resource? So I don't know, Kent, if you want to talk a little bit about, some of the capabilities of the software that are out there. Certainly interoperability, the ability to interact with your medical record, your electronic medical records. Certainly the ability for ease of creating reports and being able to bill and have your reports sign off in an efficient way so that your workflow is minimized.
Yeah, sure. That's a great point. And I think we've come to the a time now, as you mentioned, with Pacemate buying out PaceArt, that probably pushed many folks into looking at changing softwares, going to a cloud-based system, probably sooner than maybe they would have, had it not been, because we all get comfortable with a certain platform or whatever, even if it's less efficient. Sometimes we don't know what we don't know moving along. But I think it is important. We've gotten to where of course, an integration is pretty much standard. Certification, SOC certification, security, that's standard. Recall management, these types of things should be standard. Automations of things, workflows, being able to custom build reports. So I'm sure everybody on here who's used many different softwares are going to find, the main boxes that actually help your workflow are going to be checked across the board, really. But I will go back to what Mary was saying earlier on, until you have trained folks to work within these particular platforms, it doesn't matter really to that regard. And so that's where I think it's important to talk about, in addition to those things, besides what we all know is standard that we should have, having a software platform that's going to support that training pipeline for your folks, even in a production environment. I think it's extremely valuable, and that's something that we've been really looking hard at very, very closely. Because that now you take this environment that we have and you support it from the ground up through a software platform and a training program, with a partnership that can actually extend beyond just the data management. So there's a lot of things changing, and in this space, particularly with a lot of that moving in different avenues. But I'll agree with Mary about the training part of it and being able to continue that consistently, and technology should be able to support that in a seamless manner.
And I'm just looking at some of the other comments. Julie says that her device clinic had always worked very independently, but 18 months ago, they partnered for training with Accelerator, and that has been a game changer, because it is such a comprehensive program. And I think one of the things I also wanted to ask, because I think that, we're talking about training and certification. So do you, as clinicians and as maybe device clinic managers, encourage your staff to be certified? And if so, is it through EBRI? And if so, do you encourage, for those of you who have the separate responsibilities, the remote versus the in office, do you do the special certification exam that is specific to the remote monitoring, and maybe, give us some, comments on what you all think about that?
Yeah. We're getting some good comments coming in talking about Accelerator Pro and the training and its comprehensiveness. And yeah, thank you. It's quite a program. And I want to throw out there, I'm curious, for folks who are, especially proctoring and having to, utilize their teams to train new folks as they come on, how does anybody view or see additional support from Accelerator, maybe through Omni, like as a platform to provide, oversight of review of reports, a preliminary review by IBHRE certified folks that are not in your clinic, that you wouldn't have to burden, that leads to more burnout, by folks from PrepMD who do the training as well. So be in a production environment. And I'm very curious to know if anybody would see that as a value to take some of the burden off of the proctoring programs that you may do and the OJT that you may do for your brand new employees.
Well, certainly Julie feels that way. And I see some people are saying, and I think one of the great things about Accelerator is it also preps people to be able to sit for the exams, whether it's for the remote monitoring or the CCDS exam itself. I think credentialing is very important. And in my mind, I think that, oh, we got a question. Okay. But I was going to say, in my mind, I think that can also help alleviate burnout, because if you can support your team in order to be certified, it's sort of a pat on their back. And then, certain institutions even give differentials for people that are certified, where they get additional salary line, or they move up their clinical ladder if they have a program implemented like that within their institution. So there's a lot of different ways. Somebody asked a question about how to deal with burnout, and I think that's one. But yeah, if we could open up to Kay Stocky has a question, that would be great.
Hi, everybody. Thanks, Eileen. I just, kind of going off of there, and I'm at Harvard Hospital, And we have a dedicated device clinic as well that is always, these seminars are great to hear what everybody else is doing as well. But I think as far as like certifications, it's really hard for allied professionals, especially device nurses, to kind of get the recognition or the acceptance from leadership and management about getting certified. And I would love if all of our
Mm.
staff could be able to do that and, to show that we're a certified device clinic and that all of our staff members, but one, the exam is very expensive and the reimbursement, I think, from hospital systems, they don't see it deemed worthy to do our jobs. And so I guess I'm just curious to hear from people and from you, like how you would propose this to management and leadership, and then also for reimbursement. And then, like you said, for any sort of stipend or any sort of salary bump, if you're taking a certification, what's the best approach that people could, maybe kind of help me with to present to our leadership as sort of this is something that really would help guide our, for safety, patient safety, and for learning as well.
I mean, I can start and tell you that at least I've worked in 4 institutions as an EP nurse or nurse practitioner, and in at least 2 of them, we appeal to our cardiac, EP person, the director of our program, who recognized the importance of having certified clinicians taking care of their patients with devices. So they were able to appeal to administration to buy into that. And I do agree, it is ridiculously expensive. The cost for taking the practice, instruction is also very expensive. Even if you can buy a group deal, it is a very expensive proposition. And so a lot of places utilize their CME. So instead of going to HRS this year, a lot of centers, clinicians get $1,000 or $1,500 towards CMEs. At least in my last institution, you could utilize that in order to become certified. And then the incentive, then again, I think that it makes people feel less wanting to leave their position because now they've invested in the training to be able to become certified. And it's sort of a feather in their cap. And if you could further allow them to get additional salary for that, that would be great. And what in my other discussions with other institutions, they are utilizing the clinical ladder. I don't know, a lot of the magnet programs have that, where there's a clinical ladder, and they have built into the description of how you rise up the ladder is based on certification working in the specialty of the cardiac device clinic. So that may be something that you could, pursue. And then I can tell you that I also have worked in union-based hospitals where nurses are unionized, and part of their negotiations for the union was that the all staff certified for anything, outside of even EP, should receive a differential. And I know that's just a select group, maybe in the bigger cities that have academic centers that utilize unions for nurses, but that was another way, just so you hear my experience of how we got a differential, for being certified.
Jay brings up a good point here about being able to get buy-in from a clinic for certification from admin is the retention aspect of it,
Yeah.
which is huge. And again, I think I'll bring things back around to where being able to get administrative support is really what's needed through all of this. And that's what we really kind of wanted to bring up here. And anybody can reach out to us at any time. We're happy to help support you and provide those things and tools that you can do with that. But yeah, because retention is, when we get back to cost, once they start seeing, what it costs for somebody to turn over, what it costs to not have somebody trained. Liability is another big issue that I think doesn't come up very often. But when people aren't trained or you're short-staffed, it's not just revenue that doesn't come in. It also increases liability on patient safety. And I think administration, you always will have their ears on that side of it too.
Yeah, and we only have like 1 minute left remaining. One of the things we're going to talk about is, what metrics do you do to evaluate your clinic? And I know administration, a lot of it is, at least in my world, is press Ganey and patient satisfaction and surveys coming back. And I think if, as we're saying, you put all of this together and say that if you can appropriately train, and staff your clinic, and that people are happy in what they're doing and satisfied and not burned out, then you're only going to get higher Press Ganey scores and have more people, being referred to your practice because of your reputation. And to me, part of that is being credentialed, in regard to that. I don't know, Kent, did you want to make any last minute comments? It is 4 o'clock. I think we have to close our discussion today. Someone did ask, we will be putting out, I'm sure, on social media when we're doing the Device Clinic Summit, which will be on April 10th, Friday from 11 to 4, but you'll be able to register through that.
Great. No, I appreciate everybody being on. This is a great discussion, and hopefully we'll be able to take some things back to administration. And please reach out to us for anything. We would love to further the conversation, particularly around, we centered a lot of it around training today. But as Mary said, that is kind of the core spot. And I do think that it's very important to start looking at how we can communicate with administration, make the case on why they should invest in training, and then we should start looking at software more than just data management, but being able to take training from all the way through from a brand new person coming in with functional fundamental training, OJT type stuff with support of an actual software system and services from faculty and things like that through comprehensive Accelerator Pro programming in a clinic. I think that'll create a huge pathway. So would love to hear from anybody if they want to discuss this more.
Hello@prepmd.com is your resource. Hello@prepmd.com.
Yep.
Okay, well, thank you everyone so much we really appreciate your attendance. We really enjoyed the discussion. Have a great weekend and hope to see you on April 10th.
Yep.
Take care.
Bye,
Bye-bye.
everybody.